you're going live now.
Okay. So, good evening, doctor. Good evening, our team and our esteemed guest. On the behalf of Hetero Healthcare, I am Kanchan Sangle, Product Executive, welcomes you for the webinar. We have been conducting various webinars for providing updates in various therapeutic segments. So, tofacitinib is an oral synthetic small molecule that is JAK inhibitor for the treatment of RA. And unlike targeted biologic therapies, which are directed at extracellular targets, tofacitinib works at in the intracellular level. And to further understand the role of JAK in psoriatic arthritis, we are pleased to cordially invite Dr. Abhra Chandra Chowdhury on board to deliver talk on topic of JAK in psoriatic arthritis. So before starting our discussion, let me introduce our esteemed speaker, Dr. Abhra Chandra Chowdhury. He is an expert in the field of rheumatology with more than 10 years of clinical experience. Pursued MBBS from Calcutta National Medical College and DNB Medicine from the prestigious institute Christian Medical College, Vellore. And he has completed DM in rheumatology at one of the premier institute in the country, that is Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Received prestigious fellowship from the APLAR, that is Asia Pacific League of Association for Rheumatology. Also, he has many national and international publications. Apart from that, many national and international conferences he has been a part of. He is also visiting consultant at AMRI Hospital, CMRI Hospital. Apart from it, his area of expertise are management of rheumatic diseases like rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, systemic lupus erythematosus, scleroderma, and myositis. Doctor welcomes you on board.
Thank you. Good evening, everyone. So, thanks to Hetero for giving this platform. So, shall I start my presentation?
Vijay?
Yeah. Yes, doctor, go ahead, please.
Yeah, just a minute. Can you see the screen?
Yes, doctor, it's good.
Yeah. So, good evening. JAK inhibitors in psoriatic arthritis. Methotrexate, sulfasalazine, leflunomide. We have biological DMARDs, which are large molecules that must be administered parenterally, like infliximab, adalimumab, or golimumab. We have the small molecule inhibitors that enters the cellular cytoplasm and directly regulate intracellular signaling by inhibition of kinases or phosphodiesterases, like tofacitinib, baricitinib, upadacitinib. So JAKs belong to the tyrosine kinase family. So what are the mechanism of action of JAK inhibitors? So the cytokines or the growth factors, these are all extracellular. So they bind, when they bind to the receptor, it causes phosphorylation of the JAK receptor-associated Janus kinases. So activated Janus kinases in turn phosphorylates the intracellular component of the receptors, thus enabling the activation of the STAT factor. The activated STATs accumulates and goes to a nucleus and induces transcription. So JAK inhibitors inhibits this phosphorylation of JAK and in turn inhibits transcription of the genes. Now, what are the cytokines susceptible to JAK inhibition in spondyloarthritis? So this IL-12, IL-23, interferon gamma, IL-6, IL-22. These are all the cytokines which are susceptible to JAK inhibition. So we need to remember that TNF, interleukin-1, interleukin-17 are not inhibited by JAK inhibitors directly due to different types of receptor. So these cytokines mediate synovitis, cartilage damage, bone destruction, and bone formation. So what are the different types of JAK inhibitors. So we have pan-JAK inhibitors. We have JAK1 and JAK3 inhibitors. So Tofacitinib is a JAK1 and JAK3 inhibitor. Baricitinib is a JAK1 and JAK2 inhibitor. Then we have JAK1 type 2 inhibitor. We have only selective JAK inhibitor like Figlotinib. We have JAK2 inhibitor. We have JAK3 inhibitors, and we have type inhibitor. So what are the different drugs that are available? So Tofacitinib, Baricitinib, Upadacitinib, Figlotinib, these are the ones that are available. So all are indicated for moderate to severe RA. Additionally, Tofacitinib is approved for psoriatic arthritis and ulcerative colitis. So now coming to the RCTs of Tofacitinib in psoriatic arthritis, these are known as oral psoriatic arthritis trial or OPAL trials. So we'll have 3 trials. OPAL Beyond, lasted for 6 months. It is a trial of patients with psoriatic arthritis with inadequate responders to F. We have OPAL Broaden trial for 12 months, which are patients with psoriatic arthritis, which are inadequate responders to conventional synthetic DMARD and adalimumab versus placebo. And we have OPAL Balance trial, which is a long-term extension study of both of these 2 trials. Now, starting with the OPAL Beyond study. So this study was a 6 months randomized placebo-controlled double-blind phase 3 study of patients with psoriatic arthritis with inadequate response to anti-TNF. So patients who fulfill the CASPER criteria had active psoriasis at screening, had active arthritis, and had inadequate response to at least 1 TNF inhibitor. And all of these patients received a single dose of a single conventional DMARD throughout the trial. So this was a study design. So patients were on Tofacitinib 5 mg BD for 0 to 3 months, continued at 5 mg BD, 10 mg BD for 0 to 3 months, which continued for 10 mg BD. Patients who received placebo for 0 to 3 months, who successively received 5 mg BD, and placebo patients who received 10 mg BD. And after the trial period was over 6 months, all patients received entered into a long-term open extension trial of 5 mg BD. So if you look at the response at 3 months, the ACR20 response was 50% with the 5 mg dose of Tofacitinib and 47% with the 10 mg dose. Here you can see with only 24% with placebo. If you see the health associated quality of life disability index score, so it was again the lowest for patients on Tofacitinib 5 mg and then 10 mg, and high for the HACDI score was high for those patients with on placebo. So if you see the summary of safety events, both in the 5 mg arm and 10 mg arm, the 55% patients adverse events was very less, and 1% patients on each arm had herpes zoster infection. On 5 mg arm, 1% patients had other opportunistic infection, and none had major adverse cardiovascular events by 3 months. If you see up to 6 months, again, a significant number of patients had some adverse events, but none had very serious adverse events. Again, the kind of adverse events was more or less same, herpes zoster and opportunistic infections. So now coming to the OPAL Broaden trial, which is a trial of Tofacitinib or adalimumab versus placebo for psoriatic arthritis. The patients were required to receive a stable background dose of single conventional synthetic DMARD like methotrexate, sulfasalazine, or leflunomide. They were randomized to receive either Tofa 5 mg BD or 10 mg BD or adalimumab 40 mg every 2 weeks of placebo, with the blinded switch to 5 mg BD dose of Tofacitinib at 3 months or a placebo. So primary endpoint was ACR20 and HACDI. So this was again the trial design. So if we see the response, ACR20 response rates were at 3 months was 50% in the 5 mg group, 61% in the 10 mg group, as compared to 33% in the placebo group. And adalimumab response at 3 months was 52%, which was comparable to Tofacitinib. If you see in the change in HACDI score, again, adalimumab compared almost similar to Tofacitinib 5 mg BD and 10 mg BD. So coming to the serious adverse events, so around 40% patient had some adverse events, but the number of serious adverse events was not significantly high. So now coming to the long-term extension study, the OPAL Balance long-term extension study, which studied the safety and efficacy of Tofacitinib up to 48 months. So these are patients with active psoriatic arthritis who had enrolled in the past 2 trials. So patient received open label Tofacitinib 5 mg twice daily with increase to 10 mg twice daily for inadequate symptom. And they also continued the conventional synthetic demands. Primary endpoints was mainly the adverse events, incidence of lab abnormalities, and change in baseline in the lab parameters. So if you see the interim analysis at 24 months, ACR 20 at 6 months time, and till 24 months time, patients maintained the ACR 20 response. There was a sub-study of this OPAL Balance. So patients were after a period, the methotrexate was withdrawn and patients were continued only on Tofacitinib. So if you see that at 3 months time, patients on Tofacitinib monotherapy and Tofacitinib plus methotrexate monotherapy did similar. But afterwards, comparing at 6 months, 9 months, patients on Tofacitinib monotherapy also did quite well as compared to those with Tofacitinib and methotrexate combination therapy. So they have assessed the PASDAS. So coming to the OPAL Balance side effects, up to 48 months, 84% patients had some side effects, 17% had serious adverse event, and 11% discontinued due to an adverse events. So again, adverse event profile was more or less similar. Herpes zoster, serious infection, opportunistic infection, malignancy, non-melanoma skin cancer, major adverse cardiovascular events, pulmonary embolism, and arterial thromboembolism, no DVT. So the conclusion was up to 48 months, Tofacitinib was safe and efficacious up to 36 months in patients with psoriatic arthritis, and this was consistent with the previous phase 3 studies. Now coming to the efficacy of Tofacitinib with methotrexate. So efficacy and safety of Tofacitinib by background methotrexate dose in psoriatic arthritis. So efficacy of Tofacitinib was generally numerically greater than placebo regardless of the methotrexate dose. The 5 mg BD dose was more efficacious with methotrexate more than 15 versus less than 15. And opposite was observed for Tofacitinib 10 mg BD. And headache was more frequent with methotrexate more than 15 mg per week group. So what's the effect on dactylitis? So regardless of the location, dactylitis severity score improved in patients with DSS greater than 0, greater than month 1 with Tofacitinib 10 mg BD versus placebo. And for patients with DSS greater than 0, both doses of Tofacitinib led to mean dactylitis presence less than 15% or less than 2% for all digits at month 6. So PASDAS was lower versus placebo at month 3. So Tofacitinib was good for dactylitis also. So what's the effect in enthesitis? So this was published as an ACR abstract in patients with psoriatic arthritis. Tofacitinib treatment results in improvement in enthesitis regardless of the location or severity. Therefore, Tofacitinib is a good treatment option in patients with PSA who have enthesitis. So what's the effect on axial involvement? So this is still an ongoing trial. Efficacy of Tofacitinib in reduction in inflammation detected on MRI in patients with PSA with axial involvement, the PASTER trial. And this study is still ongoing. So what's the effect of Tofacitinib in patients with PSA and metabolic syndrome? People have done a post-hoc analysis of phase 3 studies. 710 patients, 41% had baseline metabolic syndrome, and metabolic syndrome did not appear to affect the incidence of adverse events or change in lipid or hepatic values with Tofacitinib up to month 3 or 6. Arterial thromboembolism and myocardial infarction were reported once in Tofacitinib treated patients with metabolic syndrome. So conclusion was regardless of the baseline metabolic syndrome status, Tofacitinib showed greater efficacy versus placebo in patients with active PSA. The Tofacitinib safety profile appeared similar in patients with versus without metabolic syndrome. So, and how does tofacitinib compare with other molecules in the different phase 3 studies and long-term extension studies? Was studied in real life, real world observational data. So this was a phase 3 studies of tofacitinib, and this was not direct comparison, but an observational comparison cohort. So if you see the hospitalization, patients on tofacitinib 5 mg were not hospitalized significantly as compared to the anti-TNF group. Even the 10 mg BD dose, the incidence of hospitalization was not significant. So hospitalization requiring parenteral antimicrobials. Here also 5 mg and 10 mg BD did quite well in comparison to the other groups. So coming to the major adverse cardiovascular events. So if you see the tofacitinib 5 mg, all the doses group, the risk was not very high as compared to the other anti-TNF group and even apremilast groups. So malignancies excluding non-melanoma skin cancer. So tofacitinib group did fairly well in comparison to the other anti-TNF group. So non-melanoma skin cancer. Again, tofacitinib, all doses did fairly well in comparison to the other groups. So the rate of adverse events was similar between the tofacitinib dose comparison cohort and the observational comparison cohort. And in conclusion, patients with PSA, tofacitinib had a safety profile similar to other systemic therapies in real-world setting, except for risk of herpes zoster, which is a well-known risk of tofacitinib. So where does tofacitinib stand as per the GRAPPA 2021 recommendations? So it is strongly recommended for peripheral arthritis in patients who are DMARD NEV. In patients who are DMARD inadequate responders, tofacitinib is recommended. It is recommended for peripheral arthritis who are biologic inadequate responders. So it has also been recommended for axial arthritis who are biologic naive, as well as for axial PSA who are biologic inadequate responders. As for enthesitis, tofacitinib has strong recommendation for dactylitis, for plaque psoriasis. Only for nail psoriasis, it is not strongly recommended. So for associated Crohn's disease, tofacitinib is conditionally recommended. For ulcerative colitis, it is conditionally recommended. And for uveitis, it's still not, it has not been recommended. So summary of the recommendations for the management of PSA in case of comorbidities. So patients who have elevated risk of CVD, we need to use with caution. Patients who have elevated risk of venous thromboembolism, we need to use with caution. Active hepatitis B or C, HIV, TB, and history of recent malignancy, we need to use tofacitinib with great caution. So the take-home message is tofacitinib is effective and safe in refractory PSA. It is efficacious in enthesitis and dactylitis, and major safety concerns are mainly infections and different cardiovascular events. So thank you all. I'd like to take any questions.
Hello, sir.
Hello.
Yeah, hello. Yeah, actually, I got a question from some panelists. That is, the first question is, sir, how long can we give tofacitinib?
So it is actually indefinite. Like biologics, we continue for quite long term. So efficacy data as per the these studies we have for 36 months, and safety data we have for 48 months. So till that time, we know that tofacitinib we can give. But we will need to continue tofacitinib for much more time in order to be able to tell that whether it still continues to be efficacious or safe.
Sir, our next question is, any doses adjustment needed on hepatic and renal impairment, sir?
No, not really. Not really much.
And sir, the next question, where will JAK inhibitor fit in, first line or after failure of the conventional drug, sir?
Well, as per the GRAPPA recommendation, they can still be first line. But in India, because the finances are still a concern, first line drug will still be conventional synthetic DMARDs, and after its failure, we can go to tofacitinib.
And next is, are there any advantage of tofacitinib over the existing drug how do they score against the biologics, sir?
Existing drug wise, usually we use Tofacitinib after failure of the conventional synthetic demands. So if we compare with the biologics, cost is the biggest advantage. Second thing is there is no need for hospitalization. So patient prefer oral therapies. So I guess as far India is concerned, cost and no need for hospitalization, these are the biggest points which stands Tofacitinib against the other biologics.
And sir, most important question I got, that is, what is your experience with the tofacitinib in terms of RA and angstpond also?
Well, RA Tofacitinib is really good in patients who are not responders to and this conventional synthetic demands, even triple demand combination. Previously, we used to give a lot of rituximab, but after Tofacitinib has come to market, the use of rituximab has significantly come down. Now, in case of angstpond, I feel Tofacitinib fares better. We also have some data by Dr. Atul Devda's group that it fares much better than sulfasalazine as compared to in patients with ACE. I have been using it upfront. I mean, after failure of NSAIDs, I have been using it upfront. So patient up to a certain degree, a class of patients do respond that they are doing quite well. Patients who have previously been taking sulfasalazine, they tell that it's quite working quite good. And even patients who have been on biologics, we have been using Tofacitinib as maintenance therapy. In those cases also, Tofacitinib is acting quite well.
And sir, in cases of seropositive RA diagnosed as malignancy, what is the drug to be preferred for active arthritis?
It depends on the type of malignancy, but mainly we will prefer like rituximab in those cases and not anti-TNF. But in again, depends on the type of malignancy, what malignancy.
Okay, and so next question, that is, in RA management, what are the advantages with tofacitinib as compared to the biological DMARD, sir?
I think we have already discussed that the
Yes,
price
yes.
and lack of no need for hospitalization.
Okay, so that's it from my end, sir. Question and answer round, sir.
Okay.
Kanchan?
Hello.
Hello.
Yeah. Hello.
Hello.
Hello. Am I
Yes,
audible?
ma'am.
Hello?
Yeah, you're audible, ma'am.
Yeah. Thank you so much, sir, for your time and detailed information about tofacitinib. I'm sure our guests are now well versed with the tofacitinib and entire background of it, how it is used, what are contraindication and everything. So, sir, we are glad to be associated with you and hoping it goes a long way for such educational treats, sir. Thank you so much.
Most welcome.
Yeah.
Thank you, sir. Thank you
Thank you,
so much, sir,
sir.
for your time, sir. And I think, sir, it will be a great interaction with us. And it's a nice presentation, sir. Thanks a lot, sir, and have a nice day, sir. Good night, sir.
Thank you so much. Good night.
Thank
Good
you
night,
so
everyone.
much, sir. Yeah. Take care.
Good night.